On to our last speaker, Dr. Minu Mathen, talking on cortical wash and IOL implantation.
Thank you, Chairman. This topic goes last. That means Cortex and IOL is last. And I am given 6 minutes, which is lesser than all other talks. So don't underestimate the importance of these two, because this is, for me, this is the stage when...
Actually, mentally, a lot of us at the end of nucleus management relax and create a lot of PCRs during INA.
So exactly. So even I also have got maximum PCRs during INA only, and most of you would also have experienced that. There is relaxation and also not taking this seriously. So no financial interest in this. So we can use a Simcoe cannula or an automated bimanual or coaxial. So Simcoe is not bad, you know. Simcoe, see the timing. So we go near the cortex, catch with a little vacuum, bring it to the center and aspirate. Just like you do in SICS, but your incision is smaller. So we can even use this also when you are transitioning or in early phases if you are scared or whatever reason. You can use Simcoe. Simcoe is not at all bad, not at all inferior to anything. It takes a maximum of 20 seconds, 25 seconds to finish off a regular cataracts cortex aspiration with a Simcoe cannula. But the problem is that many sizes of Simcoe irrigation are available. See, this kind of a flow is important. If it comes drop by drop and the irrigation is very small, each time you try to aspirate, you will get chamber shallowing. Because your incision is also not exactly fitting. It is 2.8 or 2.2, but still your Simcoe will be smaller. The other advantage is, so I buy from Indo-German. No financial interest in this, but I am just telling you what is available. That gives the maximum irrigation as far as I know. And so going through a side port is also very useful with the Simcoe, especially when there is a subincisional cortex and a small pupil. You can access the subincisional area much better. So in Simcoe also don't consider this as a very weak instrument. It can do all harm also. So if you go to the periphery and aspirate small bits of cortex, see, I just have pulled the bag from the equator. So this also can generate enough vacuum, and be careful with your Simcoes. Moving on to automated ones, coaxial gives you the maximum irrigation, needs only one port, and again the same thing, go towards the cortex, catch with minimum vacuum, and once it is caught, move towards the center and then aspirate it. So go contiguously, one clock hour to the next clock hour, because when you aspirate, the next will be free, and your flow, the aspiration flow rate, I keep it at 30 to 40 according to your machine which you have. The vacuum is moderate. Now see what happens. I try to, see, I just caught the PC. So trying to aspirate small bits of cortex, again you will catch PC. So a bottle height or active fluidics as you have in your higher machines to maintain the chamber very well, because there is nothing in the chamber. There is no nucleus. The PC is directly facing you when the cortex is taken out. So be very careful. Should not have too much of vacuum. I keep still in a highest end machine, I keep still 400. So you can go down on vacuum, do it slowly, but the chamber should be stable. Irrigation should be enough. That is the most crucial. Here you can do a cap whack by keeping very little 10 vacuum and 10 flow and polish the PC, or you can use the hydro jetting which I showed just now to make it all fly away and prepare your chamber for your IOL implantation. So yeah, the disadvantage of this is that going subincisional, we need to turn the tip down. So then you can directly catch the PC. So when there is a small pupil and the chamber is almost empty and you have subincisional cortex left, I inflate the anterior chamber, and then you can use phenocane, which is available now. If it is larger, you can dilate it on the table, and then fill the chamber, push the PC back, and then turn the tip down and immediately catch the cortex. Or what you can do is start off subincisional first. Nowadays I do all cases subincisional cortex first, when the anterior chamber is full of viscoelastic, and also when you have a lot of cortex which is protecting the capsule. She is very suggestively bringing a 5-minute this one. We realize that there is 5 minutes only left, but I have 2 minutes more. So we move on to bimanual IA. See the aspiration port. I am comparing it with the coaxial. Coaxial is 0.3. So the smallest it is, the best it is, because it will have less of surge. So many companies make with wide, large aspiration ports. Don't buy. So please go and see under a microscope and see the smallest possible. It will take some time, but it will be safer for you to aspirate cortex. And here, the irrigation is always lesser than the coaxial. So buy ones which give you maximum irrigation, have the pole high up so that you get maximum irrigation. And use the incisions which are fitting for the type of IA which you have. You may have multiple types of IAs in your sets. So every time you place one incision, some will not go in, some will go and will be smaller. So see which one you have and titrate your incision so that it just fits. No overlocking, no leaking. Then you will get much better maneuverability and much better chamber maintenance. Here again the same thing. Go towards Cortex, catch with a little bit of vacuum, bring it towards the center, raise the vacuum fully and aspirate. And then go towards your Cortex, which is adjacent to what you have aspirated. Last 1 minute. So exchange hands, you need 2 paracentesis here to aspirate the 180 degrees. The advantage is that you can reach all clock hours very easily. Very good, but you need 2 paracentesis. You need to adjust to the lower irrigation which you have. Then coming on to foldable IOL implantation. See, this is one commonly used IOL which goes into this kind of cartridge. The leading haptic is folded and the optic should be flat on the floor of the cartridge. That is very important. And then push it forwards and make sure that the plunger hits at the bottom or the edge of your optic. And then if you're using a 2.2 millimeter incision, most of us do a wound assisted one. So the part of the tip goes into the incision, not fully. So you need a counter traction with the side instrument. You can notice that my side instrument is pulling it back, the globe, keeping the globe straight. And it can be delivered into the bag fully or partially and then manipulated with your second instrument. And one thing we need to avoid is to hold the lens onto the center. Do not hold the center of the optic. Hold only at the haptic optic junction because otherwise it will leave marks on the optic. And lastly, these are butterfly cartridges which commonly are available and some are loaded, preloaded. This is partially preloaded. The lens is already in there. You need to put viscoelastic. Some of them are fully closed. So you just have to push in visco from one side and then make sure that the edges of these optic and the tip are underneath these 2 side flanges because once you close, the whole lens should be within that hollow area. Nothing should be in between the flanges. Otherwise it will get locked there and you will get a torn IOL going inside. And the leading haptic is better folded back so that it goes into the bag. And I fill always sodium hyaluronate because it forms the chamber very well and it is easily taken and completely taken out after implantation. And later on you can even use a hydro implantation also, but make sure that your chamber is always full while you inject the IOL. Thank you very much. So we have some time.
We have got 2 minutes before the next team is ready to sterilize us. One suggestion to all the people in the audience and for us on the training side also, formally look and document the technical difficulty of each surgery in the form of a Najar's risk score or any other risk score, and formally document each step, how well you perform it, using ICO Oscar FACO scoring. This is my suggestion. I found it very useful in my practice. With that, if nothing, 1 minute more. Any questions from the audience?